Welcome to Diabetes Day by Day, the American Diabetes Association's official podcast. For this month's podcast, we're going to focus on diabetes technology. And the area of diabetes technology we're going to focus on is continuous glucose monitoring, or CGM. CGM used to be something really fancy, prescribed only by specialists and accessible only to people on complicated diabetes regimens, but that's no longer the case. You see CGM advertised on TV, you see it in the pharmacy, at Walmart, and CGM is increasingly prescribed by primary care clinicians. And increasingly, we have found that CGM provides benefit to individuals across the diabetes spectrum. I'm Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University, and joining me is my co-host.
I'm Dr. Sarah Wettergreen, an assistant professor in the Department of Clinical Pharmacy at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences. In this role, I practice as an ambulatory care clinical pharmacist at the UC Health Lone Tree Primary Care Clinic.
Today, we're going to talk about CGM with two esteemed guests joining us. The first is Davida Kruger, who is a certified nurse practitioner practicing in diabetes care at the Henry Ford Health System in Detroit, Michigan. Davida has extensive research experience in diabetes and CGM. In fact, she's published articles and videos in the journal Clinical Diabetes. I actually used some of those articles and videos for a lecture I put together on this subject. Davida has co-authored many important articles in journals like JAMA and the New England Journal of Medicine. Davida, it is such a pleasure to see you again. Welcome to our podcast.
Thank you both for having me. I'm excited to be here.
Also joining us is Dr. Morgan Stewart, who is a clinical pharmacist at Community Care, a federally qualified health center clinic in Austin, Texas. She is faculty at the University of Texas at Austin College of Pharmacy. Morgan has practical experience in helping lots of people overcome barriers to accessing technology and has personal experience with using CGM herself. Welcome, Morgan.
Thanks so much for having me. I'm excited to share both my professional use of CGM, but also my personal use most recently.
Thank you both so much for being here. I'm excited for our conversation today and want to dive right in. Davida, I'd like to start by asking you a question first. Can you please explain what a continuous glucose monitor or CGM is and how it might be helpful for someone who is living with diabetes?
Absolutely. So first of all, I've been known to say that we need to make continuous glucose monitoring a right, not a privilege, so that everybody who has diabetes can be afforded the opportunity to utilize CGM. What CGM is a little device that the person with diabetes wears on their body, usually on the arm or the abdomen. It takes a small amount of interstitial fluid from the body and continuously gives them glucose data. So at any point in time, they want to know what's happening with their diabetes. They can look on their phone or a monitor, and they can get a number that helps direct how they manage their diabetes care. It also gives alarms and alerts. So I always think about, what would it be like to have diabetes and fear hypoglycemia? How do you go to bed at night and fear, oh my goodness, I might have hypoglycemia? Well, a continuous glucose monitor gives that person warning when their blood sugar is trending low or is low, or trending high or trending high, going to be high or going to be low. As a healthcare provider, it gives me mountains of data, but it does it in a way that is very manageable. So I can look at graphs and charts, and whether I'm steeped in diabetes care the way I am or primary care, it's easy to understand the data.
So, Davida, can I ask you? You mentioned the hypos, which are critically important for patients to know about. What are some other advantages? You talked about a lot of information. What is the advantage of all that information for people with diabetes?
So for people with diabetes to be able to know at any given moment what they're doing and how it affects the outcome. So for instance, I decide to walk to the end of my block, whatever, or a mile or 2 miles. I can watch what's happening and see the impact of the changes I want to make in my life. I have a high carbohydrate meal or a protein meal, and I can see what those foods do with my glucoses. It helps guide my life in an easier way to give direction. And we've seen research that showed without changing medication, just giving the continuous glucose monitor to our patients, you could see with no change on oral agents, even 2% lowering of the A1C.
Davida, I'll tell you, that to me has been the biggest aha moments in taking care of people with diabetes when I give them a CGM and it creates that quick feedback loop. And it's one thing for I or a dietitian to tell a patient that when you eat certain foods, it's not good for you. And then months later, you see your A1C, maybe it isn't good, but it's hard to connect the dots. The difference I've seen, I was so happy to see that article that you mentioned when it came out, because the difference I've seen in the office in how engaged people are with their own diabetes care, how it changes behavior, because the feedback loop's immediate. I know, Morgan, do you have any thoughts on this?
100% agree with you there on the real-time feedback, right? We all want those instant results, right? I can speak from experience that we all like to think as well that we're the exception to the rule. So I can share a story that, I know smoothies have a very high sugar content. And I said, no, smoothies, they're great. They have those superfoods, whatever, right? I'm the exception. And of course, I see my glucose rise at a very alarming rate. And it definitely reinforced like, yep, nope, I need to go for a walk now. And you get that instant feedback.
That walk now is very interesting because now there's information that walking after meals can be very helpful in blunting that spike. And that's so interesting that you noticed that. I had someone I take care of recently that mentioned a similar thing. Sarah?
Absolutely. I just want to share my own practice experience too. Just last week, I helped someone that I work with in my clinic to get started on a continuous glucose monitor for the first time. Their A1C was around 11%, hesitant to take medications, but really motivated to work on changing diet and understanding the foods a little bit better and how they change their glucose. So this person used a CGM. The first day is calling me like, I had no idea this is what my numbers looked like. What can I do? We helped this person get started on insulin. And within 3 days, the numbers went from an average of around 300s to around near 200, upper 100s.
Wow.
So almost in half, just in that a little bit of time, but mostly was driven by this person's change in their behaviors. This person started eating different types of meals, adjusting their exercise pattern, and really saw dramatic changes right away. So it gives people control to say, I feel empowered now. I have the information that I need to make informed decisions. And I think that's so important.
Davida, I'm interested. You have been one of the researchers that have been instrumental in moving CGM from that complicated person on multi-dose insulin to then a paper you published was instrumental in getting, I believe, Medicare to acknowledge the importance for people on just once a day daily insulin. Your thoughts about how it really is more broad than that, not just complicated people, not even just people on insulin. Is it useful in the way that we've been saying for anyone who might have diabetes?
I think the research shows it. The A1C shows it. The patients will tell you they need this. And I think what's important to understand is that diabetes, and I think Sarah said it so well, diabetes is a self-care disease. We don't go home with our patients, and I always tell my patients that's a good thing for them and a good thing for me. That I don't go home with you at night. I might be available to you, but I don't go home with you at night. And I think we want people to own their own destiny and their own diabetes. And that's what CGM does for them. So in the beginning, when the devices were really complex, they didn't have the greatest MARD, which is our accuracy standard. And now we know that they are, within 8 to 10% of the lab. No matter what you do, you put them on, you run with them. And we know that people are getting constant feedback. We also know that type 2 diabetes is a complicated disease, and it has a lot of complications with it. And whether you're on insulin or you're on oral agents, we need to have a better outcome for you. And so the research is showing that those individuals who are just on several in either one injection a day or several oral agents will benefit by lowering the A1C. And when you think of cost, probably is cheaper to give someone a CGM than another medication or to move them to insulin. And so we were able to show that A1Cs come down, that he can show that people on oral agents, by just giving them continuous glucose monitoring, he saw 2% lowering in the first 3 months. So why wouldn't we want these individuals? And you are correct, Medicare has been amazing. They're now saying that one injection of insulin a day, or someone who is having documented hypoglycemia. If a patient has sulfonylureas and having hypoglycemia, they qualify for continuous glucose monitoring.
Yeah, it's so exciting to see this expanding coverage. I've definitely seen that already have big impacts in my own clinical practice site. Morgan, I'd like to jump to you. I know one of the things you've commented on a bit already is some of your personal experience with using CGM devices. To start, can you share a bit more about your story and how you started using CGM yourself?
Yes, absolutely. So I've been involved as a clinician in the diabetes space and diabetes technology probably within the last 6-ish years. And so definitely a lot of experience on the back end, but never personally worn any until about the last year. I was actually diagnosed first with pre-diabetes, and I asked my clinician, hey, I know this is probably not going to be approved by insurance, which I'm sure I'll talk about more of access later, but could I just gain access to a CGM? I want to know, I want to be engaged with my numbers. I want to kind of face the numbers as well, versus waiting that 3 months of repeating and not seeing any instant result. I'm definitely someone who enjoys those instant gratification, if you will, of being able to see what I'm doing. Was that walk worth it? Was that exercise worth it? Was that salad worth it? And so that's how I got started. But most recently, where it has been a game changer for me, we found out in January we're expecting a little one, and pretty quickly found out I also have gestational diabetes. And this has been a game changer for me in terms of just feeling that I love the word you used earlier with empowerment. I feel so much more empowered to take control of what my numbers look like. What am I doing? Do I need to follow up with my practitioner a little bit more sooner to talk about any med changes that might be needed? And it has definitely just given me a lot more control of what I feel I can, you can't control much, unfortunately, in pregnancy of what's going on internally. But this, I feel like I can definitely have a more hands-on role in navigating that.
With that, Morgan, I know that from your practice side, you do remote patient monitoring and you see the data of the people that you're working with to help with their diabetes as a clinician. And now as a person living with gestational diabetes yourself, you're sharing that data with your care team. Can you tell us a little bit about how having that information available to your care team as this, risk level has changed for you has been impactful?
Oh, absolutely. I will say so, I work full time. I have a very busy clinic, a very busy, on the teaching side, the academia life is very busy, as I'm sure you all know. But so what for me, being able to remotely share that data, I'm able to just jump on a quick phone call with my healthcare practitioner or a video call with my healthcare practitioner and say, hey, I just, I looked at my report. What do you think about these numbers? Let me show you what was happening. And it saves me, 2 to 3 hours as opposed to traveling to the clinic, letting them download the data, waiting for the practitioner, driving back to work. And so I feel like it's changed so much, the ability for me to have flexibility and not feel like, gosh, this disease state I have is controlling my everyday life. I have to take off work from this. There's so many, barriers to it. So being able to have remote access or give remote access to my practitioner, so helpful. They also do what's called remote check-ins, where in between my visits, they'll just glance at my report, double check everything looks okay. And then, if they don't need to talk to me because things look great, they'll let it go, but they might proactively reach out because they can see my numbers, and I've given them permission to do that because I would love that extra check as well. So it's kind of nice to see it from the other side of things. Sometimes I feel like as a practitioner, I'm always worried, like, gosh, I hope my patients don't think I'm creeping on them or being that person that's just like, overarching big brother looking at them.
Like, Morgan, what did you have for lunch?
Funny story. My own father actually will not share his CGM data with me because he's scared of that.
Oh my goodness. Yes.
I'm going to call him, what was that cookie you just had, or, whatever. But no. I mean, honestly, I think it's been really nice to be able to know someone cares enough as my practitioner to check in on me, to look at these things, and to have access to that, I think is huge.
Davida, I'm curious your thoughts as someone working in the endocrinology space and with people with using CGMs all the time. Can you share a little bit more about your perspective?
Sure. I think I agree with Morgan in terms of virtual connection with our patients. We forget that, for most of my patients, we require them to be seen every 3 months to make sure that everything's going smoothly, that we have the data, we can give them feedback. And I think the pandemic sort of kicked us in the butt to do this, is that we are set up that every patient we have on CGM is connected. I would say 90% of ours are connected through a phone or know how to upload at home. If they don't, family members help them, or they do have to come in and sometimes, even just run in and we upload and get the data. I would tell you that given the volume of how many we see, we have to handle it a little bit different than Morgan described, because if I had to glance at over 2,000 people wearing sensors every week or day, I don't think it would be possible or reasonable. The other thing is, I really want my patients to take a look-see before I do. So I will say to them, we just made a change. In 2 weeks, would you remind me to look at your data again? Or would you ask me to? Or if you see something that's not there yet, ask me to look at your data. And that really engages the patient. The other thing it does is that I don't want to miss anything. So it has them help me out. And I even have a smart phrase that says, although we're connected, I will not look at your data unless you ask me to. And I think as a clinician, that sort of legality helps me as well, because if somebody's having a lot of hypoglycemia and I'm not looking every day, I don't want to miss it. I want the patient to be engaged. I think the beauty is that we can be engaged on a regular basis. And every time I change something, I'll say, please look and let me know what else needs to be changed. And I love that connectivity and love the fact that my patient can say, I have to work, but I want to have a visit. Can I do a virtual visit on my lunch hour? Sure, you can. Or can I do it at 3:30 because I'm done? It's unlimited what we can do for our patients with this connectivity.
Davida, I love what you just suggested about empowering patients, giving them the responsibility to look at the data they have and the opportunity to prompt us by reaching out to us to talk to them about it. In many primary care offices, we're not as connected, Morgan, as you described, with downloadable access, because we take care of such a range of disease states. It is not to the point in many offices where in each of those disease states where there are remote monitoring devices for blood pressure now, for peak flow, for respiratory disease, it becomes complicated. But Davida, I think I'm going to start doing what you just suggested. I love that idea that I've been doing a lot of telehealth, but with pre-scheduled visits, to say to patients, reach out when you think you need help, and we'll go over your CGM information. And for people who are listening to this podcast, I know primary care well, and I know that you can make those recommendations to your doctor. If we don't think of it, what a great opportunity. Again, one of the themes that Sarah and I have on all of our podcasts is patient empowerment, that you can make the suggestion to your clinician to say, hey, I got an idea. You gave me the CGM device. Can I call you when I have questions? Sarah?
Absolutely. And I think there's so many benefits to these devices, as you can hear from our discussion. But regardless, I think we've all probably heard from people that we've worked with, there's some hesitation maybe in using these devices. Morgan shared that her dad was, curious about sharing the data, a little hesitant to do that, thinking people might be watching them, might be worried about, how complex is this device? So I want to jump to you first, Morgan. Can you share a little bit about your experience with the devices? If someone is hesitant to use a CGM, thinking of the complexity or just the overload of information and the potential to be overwhelmed, how would you share that information with someone?
Yeah, absolutely. And I'll preface this that while I know as a patient, having all this access to data looks a lot different due to, different just resources I have in my life. I actually work at a clinic as a clinical pharmacist, mostly in the diabetes management side of things for an FQHC, or a federally qualified health center. So about 75 to 80% of my patient population does not have insurance, also struggles with low health literacy, regular, issues with literacy as well. These are definitely patients who are underserved and don't have as much access to things. And a lot of the barriers that we've already brought up are huge here. So we think about cost as being one of the biggest barriers we see. Information overload. I can't tell you how many patients we finally get access to a continuous glucose monitor, and maybe one of the ones that's intermittently scanned. So something like a Libre device, the 14-day or the Libre 2. And we finally get them access. We, got approval, whatever we can to get it. And they come back to me 2 weeks later and say, you know what? I didn't scan because I knew it was going to be high, and I didn't want you to see the information, nor I see the information, because I thought I'd be in trouble. And I think that all goes back potentially to that trust someone has with their clinician, that, this isn't about, this isn't something to get you in trouble or make you, scared, or, this isn't like a disciplinary action by any means. It's to give you information. And that's where I think it's been really helpful for me to almost talk from my patient side of things of, this is the information I've been able to use. Here's how I've used it. Yes, it's scary when you see that high number and you're like, gosh, I didn't do anything. And I think it can also help patients feel a little bit more like it's not their fault, if you will. Like sometimes, we think this, therapeutic lifestyle change is going to be the miracle that works for us, right? And it's not. Sometimes it can help patients kind of come to terms with their diagnosis as well. But I think also people fear just even that they're not adept to using the technology as well. I've had a lot of my patients, whether it's they just have had limited access to technology, or maybe they're in a different generation where technology is not their forte. A lot of patients will say, no, I don't really want to do that because I'm kind of fearful I won't know what to do with it. And that I think also can go back to that trust you build with that patient of what resources can we provide you? Let's spend a whole session talking about just this. But definitely, unfortunately, a lot of barriers to some of the CGM devices.
Davida, I'd love your thoughts next, as you've led many of the research opportunities within this area, helped with getting more access, and we know that these devices have changed over time. How would you explain to someone who's maybe nervous to use a CGM for the first time, kind of the ease or difficulty of use of the current products available?
So one of the things we try to do in our clinic that I think is really helpful is use professional CGM first, if people are at all hesitant. And that gives them a 10 or 14-day trial on what it is and what it isn't. and let them see the data. And I have to tell you, some of them are like, do I have to return this? Yes, you have to return this because it's going to end in 10 to 14 days, and let me get you your own. So I think that's a nice way for people to see what it is and what it isn't, on some that are unblinded, to actually see the data and the difference it makes in their lives. There are going to be people that this isn't for, just like finger sticks was not for, or you have to talk them into injectables. But what I'm seeing in 2023 is people calling and saying, I saw it on TV, I want it. And then we actually try to line up a device that works for that particular individual. I think with the advent of the newer devices, even with the brands that used to have to be scanned that are no longer need scanning, those that, can be worn and go right to your phone. I think that's so important in the fact that, pretty soon everything will have a reader if that's what the patient prefers. We prefer having it on the phone because then we know the device, the data comes directly to us. The big change I have noticed is that once a patient gets the thirst for it or the trial for it, they don't want to give it up. And once they're wearing it, it used to be like, insurance companies were afraid that if we gave them CGM, they wouldn't use the device. They'd put it up on the shelf, the device would expire, and they'd have paid for it. Not happening. And what happens now is like people are hyperventilating because they called either the pharmacy or the DME to get their next batch. And it's going to be 2 days, and they may be a day or two without their device. And I'm not minimizing the importance. I'm just saying the change is that people don't even want to go a half a day. They don't even want the warm-up periods that are needed with CGM. So the whole thing has changed. Again, I know my world is a little bit different. And then to speak for sharing. So I don't share with patients because you understand why, but I have friends who have diabetes who have said, oh, please, why don't you share for me just for a month or so and help me? I'm done with that because I was sharing with a really good friend and I'm looking at him saying, oh my God, what's happening? I called the person and I said, what's happening? And he said, I'm on a date, I'm at a bar, back away from my sensor. So, I've had a few situations like that and I choose not to share, but the big thing is people need to share with people that they trust, that will support them, help them stay safe. Like your father, I think that's marvelous for him to stay safe if you see something, but you have to pick the right people. And research will show that, especially in younger people, if they share, their A1Cs are better. So
that's so fascinating, Davida. And I know in the psychological literature, there's the term a behavioral coach, and you have to pick that person carefully. It can't be someone who, when they give you feedback, you get upset at them, right? But the right person to share data with, not like we share our biking things on Strava, so everyone knows how far we went, but rather a select few can be very helpful. We only have a few minutes left. Davida, I'd like to ask you to go first. Any final thoughts that you want to share with our listeners?
Well, it's never, ever a good time to have diabetes, but this is about the best time with not only the devices we have, but the medications. And the single thing that has turned diabetes around, from my perspective, is continuous glucose monitoring. It will continue to grow. It will continue to enhance not only the lives of people with diabetes, but for those of us practicing in diabetes to be able to really genuinely help our patients with diabetes.
Fantastic. Morgan, your thoughts?
Yeah, I'll end by saying this, and I want to capitalize on what you said earlier about advocating for yourself. And I'll just share very briefly that, when I first tried to get access to CGM, I alluded to it's probably not going to get covered, and even when I was diagnosed with gestational diabetes, my insurance denied it twice. We tried to put in a prior authorization. And I asked my healthcare practitioner, is there any way we could submit an appeal? I can help you write it if you need to, whatever we need to do to make sure, can we appeal this to, there's data out there for gestational diabetes. And, thankfully my practitioner is amazing and said, no problem, I got you. Let's submit an appeal. And of course we got covered after that. So now instead of paying a couple $100s every month, I'm paying zero for my continuous glucose monitor because I really just advocated for myself to say, no, please, let's talk to insurance again. Can we appeal this decision? So with that, I agree with everything we've said, that like Davida said earlier, that CGM should be a right. It should be a right to anyone who has glucose abnormalities. And so definitely taking ownership of your own health, advocate for yourself, and feel empowered by that as well.
Morgan, I'm so glad that you shared that specific story. My dad used to say that a wheel is the perfect instrument for movement, but it doesn't move unless you push it. And that's what our system is good. It's filled with caring people, but no one cares as much about ourself as we ourselves do, and we should be our own best advocates. And often when we push, the system responds. Thanks so much for that critically important story. Sarah, your thoughts?
I would just say, as we wrap up, I think we've seen so many benefits that we've talked about today related to continuous glucose monitoring. And one of the barriers that I've heard from people often is the concern about how much this data could potentially be overwhelming. So trying to go in with an open-minded perspective of, we're not expecting perfection of any way of your life. And this is an area you also should not expect perfection from yourself. You don't necessarily need to have your glucose numbers within the target range between 70 and 180, 100% of the time to be meeting your glucose targets. And we know that things happen, and you should give yourself some grace with that too. If you do have glucose excursions occasionally, whether you're using CGM or not, that can be expected and can be normal, and just learn from it and continue to move forward day to day, because we know that there's a lot you're managing day to day, and glucose is just one of those things. So hopefully that will change the perspective and give you some less overwhelming sensation with use of these.
Such important advice. Morgan, I want to thank you for joining us.
Yes, thank you so much for having me and using this platform to share my story.
And Davida, of course, it's always a pleasure. Thanks so much for joining us.
Thank you for having me. This was great fun.
And Sarah, my co-host, always a pleasure.
This is a great discussion. I can't wait for next month.
And to our audience, thank you. Tune in next month, where we're going to go over facts and fiction, discussing things we've heard about diabetes management and separating out which are fact and which are fiction. We now have an official podcast phone number, 703-755-7288, where you can call and leave a message with any questions or comments about our current episode, and we may read and discuss that question and comment on a future podcast. Also, if you have any suggestions that you would like for us to discuss on future episodes, don't hesitate to let us know. That phone number is 703-755-7288. For the American Diabetes Association, I'm Dr. Neil Skolnik. Thanks for listening.